medcram.com.
Welcome to another MedCram COVID-19 update. We're going to talk about something that we talked about very early on in the pandemic, something going back to March of 2020 when we were looking at early treatment, and we were discussing hot-cold therapy, specifically hydrotherapy. And this is going to get into some immunology and also SARS-CoV2 and the actual virus itself. Really important topic, especially in light of future pandemics and what we can do to prepare. So this is probably one of the most important videos that we've done because we're going to talk about some new research that adds validity to this idea of interferon and what we can do to our own bodies to improve and increase and enhance interferon secretion in our own bodies. But first, I wanted to tell you a little bit about me. This is Dr. Roger Schwelt. I'm board certified in internal medicine, pulmonary and critical care disease, and sleep medicine, and also the co-founder of MedCram.com, where we offer continuing medical education topics and CME and medical education topics, not just for healthcare providers, but also for anyone else that is interested. Okay, let's get into this. We've talked about this before. You may have even seen this slide before. The immune system is so amazingly complex. In fact, so much so that if any virus wishes to invade the human body, it needs to get past a number of barriers. We've talked about the innate immune system, which is right here, and also the adaptive immune system, which is right here. So the adaptive immune system is the part of the immune system that after either infection or vaccination is going to make not only T cells, but also antibodies. What we want to talk about today is the innate immune system. This is the part of the immune system that actually has natural killer cells and monocytes, which are macrophages. So this is the part of the immune system that can recognize that something is foreign without actually seeing it before. It knows that the molecular patterns of that foreign invader are so different that things like natural killer cells, monocytes, macrophages will eat them up and actually destroy them. And you can see them here. One of the major components of the innate immune system is interferon. Interferon is extremely powerful. It really messes with any kind of viral infection, such to the degree that if a virus wants to infect your body, it has to come up with ways of getting around interferon. There is no viral specimen out there that's going to be able to infect the human body without first getting around interferon. It's almost like trying to break into a facility and not knowing how you're going to get past the key or the guard. Interferon is that important. And this was really made clear in this article that was published in Nature back in 2002. And it's about this idea of viruses and interferon, this fight for supremacy. So I want to read to you what it says here in this article. It says here that type 1 interferons are a group of antiviral cytokines that are induced during viral infection by viral replication products such as double-stranded RNA. This is part of the genome. Any kind of foreign genome that is introduced into the cell is going to exert this intracellular interferon signaling pathway, which is really important. This eventually induces the expression of large numbers of ISGs. These are interferon-stimulated genes, very important in shutting down viral infections. These ISGs are the workhorses of interferon response, and they set up an antiviral, antiproliferative, and immunoregulatory state in these host cells. However, most, if not all, viruses have evolved a broad spectrum of strategies to block and interfere with the interferon pathway. This is really important, and we'll show this later. SARS-CoV2 is not unique in this factor. It has genes that are packaged to specifically reduce, immobilize, diminish the body's ability to be immune to them, and specifically it does this through interferon, as we'll show you. And so it talks about basically different strategies and different places that are interruptible in the intracellular process of making interferon. So interferon is really, really important. And it takes us to a paper that was published at the very beginning of the pandemic where they looked at relatives of SARS-CoV-2. Specifically SARS and MERS. After studying it, they showed that interferon responses were delayed. They say here that SARS and MERS had higher viral loads and delayed interferon responses. Thus, it could be that patients most susceptible to severe disease are those that cannot mount an effective early antiviral immune response. At this point, it was mere hypothesis about SARS-CoV-2, But in fact, it turned out to be correct. They even said here that type 1 and type 2 interferon responses were highest in patients with mild to moderate disease and were low in the patients with severe or critical disease. A similar difference in type 1 interferon activity was detected in the serum from patients. Patients with more severe disease had less type 1 interferon activity in their blood. So why are we even talking about this? Because here the body has a way of dealing with a broad range of different viruses. That variableness is already built into your immune system. So instead of individually try to affect different viruses or even different variants of the virus, one way of mitigating against many different types of variants, many different types of viruses, is if we could simply promote or enhance the body's already innate immune system to deal with this. In other words, heighten the guards that are on duty, heighten the keyed entrances so that people cannot break into the facility, so viruses cannot break in. Let me show you what they found here for SARS-CoV-2. For severe COVID-19 patients, that mild disease had higher amounts of interferon than critical disease, which had lower amounts. This is not correlative alone. There is actual causation here because we know that interferon is specifically responsible for preventing a foothold of viruses inside the body. Based on that, it would make sense if we could find, for instance, the actual gene in SARS-CoV-2 that allows entry of the virus into the human body. And sure enough, this paper that was just published in August shows pretty clearly, and there's actually a lot of data in this paper that we're not going to get into. I want to just briefly show it to you, but of course, we will put a link in the description below. This article shows pretty elegantly that the MAC1 gene is, as it says, required for interferon antagonism and efficient viral replication in cell culture and in mice. So this gene called MAC1 is what gives SARS-CoV-2 its ability to get past the guards, to get past the interferon secretion in the cell. So interferon is really important. And it's MAC1 that is actually causing the problem. So let's take a look at this a little bit more carefully. We see the gene product of these different genes that make these proteins. Here's MAC1, as you can see right here. And more specifically, we see here in the ORF1AB gene area, MAC1, and specifically we see that they have given specific deletions and mutations. And the question is, what would happen if they checked on the virus's ability to infect different cell types with intact interferon responses? What would happen if they mutated or put a gene deletion in that MAC1 area? How would that change things? That's exactly what they did. They used these cells called Calu3, which are bronchial cells, and they use these cells here, which are the A549ACE2, which are alveolar cells. The blue is the wild type virus, in other words, the virus with all of its genes intact. The orange is the delta MAC1, which is where they now have the gene deletion. Now notice, when they are checking for interferon responses in both the bronchial cells and the alveolar cells, the deletion causes and allows a much higher interferon response in all of these situations. They also see that here, as you can see, in the alveolar cells as well. They also noticed that those cells were able to kick out the virus much faster. And so therefore, it seems very reasonable to say at this point that MAC1 is very important to the virus for its ability to infect, to get past the body's innate immune system and defense. And that's important whether or not it's the wild type virus, Omicron, or anything in between. And it's also safe to say that this type of viral response is also extremely important, not just for SARS-CoV-2, but for a number of different viruses. And it seems that if a virus wants to get inside, it's got to get past interferon. The question would be, is it possible that we could boost interferon and that would help us regardless of the variant, regardless of the virus? Actually, there's been some good studies done on that. This is one here that was recently published this year in February of 2023, looking at something called pegylated interferon lambda. Pegylated interferon lambda is basically interferon, but it is packaged in a way that it can be given and it can act over a long period of time. So let's take a look at this randomized control trial published in the New England Journal of Medicine, prestigious journal, back in February. And they had a number of subjects in this study. It was a randomized controlled trial, almost 2,000 subjects. As it turned out, vaccination did not matter in terms of inclusion or exclusion criteria, although they did look at them separately. 83% of the people in the study were vaccinated and 17% were not. Spoiler alert, it doesn't matter if they were vaccinated or unvaccinated. The medication had a similar effect, which was positive. And so what they did here was they looked specifically at outpatient COVID-19 patients, and they wanted to see as an endpoint, could they prevent hospitalizations or emergency room visits? And this was a single subcutaneous injection of pegylated interferon to patients presenting within 7 days of coming down with symptoms. So let's see how they did. Let's take a look at some of the data. Looking at all cause, when we're looking here at the intervention treatment, there was 931 subjects in the intervention group, and there was 1,000 in the placebo group. And what they found was in the pegylated interferon lambda group that 25 out of 931 subjects came down with either a hospitalization or emergency room visit within 28 days of getting a positive COVID test. That was only 2.7%. As opposed to, in the placebo group, 57 out of 1,018 that came down with hospitalization or emergency room visit with a relative risk 5.6%. That is a reduction going from 5.6 to 2.7 of a 49% relative risk reduction. So 50% relative risk reduction sounds pretty good. If we do the absolute risk reduction on that, that's a 2.9% absolute risk reduction. And so therefore the number needed to treat, which is simply the reciprocal of that, is 35, meaning that you would have to treat 35 people with pegylated interferon lambda to prevent one hospitalization or emergency room visit. Now that's not too shabby. It's actually pretty good. Let's take a look at some more data that came from the study. Here we look at hospitalization or ER visits according to vaccination status. Here on the left, we have all of the data for those that got vaccinated, and on the right, those that were unvaccinated. Looking at the supplementary material of the protocol, it looks as though vaccinated meant any vaccine injected at any time. Although they did say in the protocol that people enrolling in the study had to wait at least 2 weeks for vaccination. That was from the enrollment of the study. But what we can see here is in the vaccinated population, those that received pegylated interferon lambda was 19 out of 786, meaning that 2.4% of that population had an ER visit. Whereas in the placebo group who were vaccinated, that was as high as 4.6%. So still approximately about a 50% relative risk reduction. In the unvaccinated group, the placebo group had an ER visit of about 10.2%, and there was actually an even more than 50% reduction in ER visits or admission to the hospital, going down to 4.2%. So again, it seemed to benefit whether or not the subject was vaccinated or not. In terms of the placebo versus pegylated interferon in terms of COVID-19 related hospitalization or death, which is very rare, we can see here that it went from 3.9% in the placebo group down to 2.4%, which was a relative risk reduction of 39%. We talked about efficacy. Let's talk about safety. In terms of adverse events, there was actually less adverse events in the pegylated interferon lambda group than there was in the placebo group. And so this all led them to come to the conclusion that the risk of COVID-19 related hospitalization or an ED visit was approximately 50% lower in the interferon group than in the placebo group. Results were consistent regardless of vaccination status. And in terms of safety, similar in the two groups. It seems as though if you could increase interferon levels, you could actually do something quite impressive with reducing hospitalization and ER visits, something that we talked about back in update 46 and 47, that if we could reduce the number of people that had to go to the hospital or to the emergency room, that we would be less likely to have to flood the hospital system with so many patients and avoid the crisis that we saw, for instance, in states like Idaho and Utah, Texas, Montana, where there was a huge surge in sick people going to the emergency room. We also saw that here in California. Fortunately, the hospital that I worked at never had to go into crisis protocol, which is where basically you suspend standard of care and you have to decide who gets what. If there was some way that we could increase the endogenous interferon secretion by itself, something that would be effective against any variant of SARS-CoV-2, and maybe reduce the population going to the hospital, that might be something worthwhile looking into. And so, in fact, we looked at this paper. Hyperthermia in humans enhances interferon gamma synthesis and alters the peripheral lymphocyte population. And what it showed was that a temperature threshold of 39 degrees Celsius for this response suggested potential relevance to fever. During an infection, the innate immune system causes a fever, and that fever can cause a number of downstream events, not the least of which was found in this study, which showed conclusively that when you got to 39 degrees Celsius, there was a 10-fold increase in interferon released from lymphocytes after mitogen stimulation at different body temperatures. So 39 was the most. Now, a mitogen is simply telling the lymphocytes that there's something bad out there that needs to be taken care of. And when you increase the body temperature to 39 degrees Celsius, there is a tremendous increase in that amount of interferon. This is probably even higher. We'd have to look and actually see the data on that. What I'm saying here is that an increase in interferon endogenously with the stimulation of heat may be able to simulate some of the findings that we're seeing in the New England Journal of Medicine with this pegylated interferon lambda. Unfortunately, there are no randomized controlled trials, and this is something that I think is sorely lacking. Is it possible that initiation of interferon gamma through a body temperature pathway could be beneficial? Well, as it turns out, this is not a new question. In fact, you might be interested to know that this was the standard of care before antibiotics were even discovered. If we go back to the Battle Creek Sanitarium in the early 1900s, even in the 1800s, this was something that was done very often. Here's a photograph of a whirlpool bath, which was used for heat to increase the patient's body temperature. This is at the Battle Creek Sanitarium back in the 1910s. The reason why water was used is because water has a very high enthalpy, which means it can transmit a lot of heat in a small amount of volume. Some other things that we're seeing there at the Battle Creek Sanitarium, things that are near and dear to my heart. This is an electric light cabinet. They even knew at that time that light was beneficial. This was the staff back at the Battle Creek Sanitarium in the 1890s that were on task to give the baths and to do the hydrotherapy, which increased the body temperature. They did a number of things. They would have these patients lie down on beds, and they would heat up towels that were soaked in water, and they would place these towels that were very, very hot on these patients with maybe 1 or 2 layers of protection to prevent them from burning. That's the big side effect, of course, of this, is to prevent burning of the skin. But what this would do is it would increase their body temperatures. They had no idea about what it was doing in terms of interferon, but they noticed that they were getting results. A number of people came to this Battle Creek Sanitarium. Amelia Earhart, the actor that played Tarzan way back in those old movies. Sojourner Truth, C.W. Post, who of course made his Post serial, along with John Harvey Kellogg, who was actually the medical director of the Battle Creek Sanitarium. Mary Todd Lincoln, Henry Ford, who of course was nearby there in Michigan, Eleanor and Teddy Roosevelt, George Bernard Shaw, and John D. Rockefeller. You can actually see a picture here of President Taft going around the country and talking to people about monopolies and the antitrust. And you can see here the guy wearing white. This was his telltale suit that he always wore in white. That's John Harvey Kellogg. And as you can see here, this is the end of September in 1911. This did not happen in a vacuum. This was well known at the time. And of course, when the 1918 pandemic hit, the flu pandemic, there was definitely some opportunity to look at this type of therapy. Basically, the two types of thought here. One was that during the flu, the fever was causing the problems. The flu was the result of the infection, and it was resulting in morbidity and mortality. And that's kind of the thought process that most of the army hospitals at the time thought about. And they knew that aspirin, which had just been introduced in 1899 by the German company Bayer, killed fevers. And so they felt that if they gave enough aspirin to their recruits and to the people that were coming down with influenza, they could somehow mitigate the downstream effects of that fever and stop a lot of the ill effects of the influenza virus. On the other hand, fever was looked at by Wells Rubel and his collection of Adventist sanitariums on the East Coast as being beneficial, as being part of the immune response, even helping it along. So they refrained from using aspirin. In fact, they did a completely different type of treatment at their sanitariums. Dr. Rubel, who later became the president of what is now known as Loma Linda University, wrote this in 1919. He said, "The present epidemic of influenza has furnished excellent opportunity to test out the efficacy of rational treatment in dealing with respiratory disorders, especially in conditions accompanying and following attacks of influenza." We've talked about this actually before. This is not a scientific journal. This is the opinion of an observer at that time. That's why I put it in here at the time. He observed what was going on both in his sanitariums and also in the Army camps. And what you can see here, based on his article, these are not verified numbers. This is not a scientific journal. This is simply him reporting this, is in the Army hospitals very early on where aspirin was used extensively. Aspirin kills fevers, of course. About 16% of those that came down with the virus, influenza, developed pneumonia, as opposed to only 2% in the sanitariums, where fever was actually encouraged, in some cases actually developed using hydrotherapy. So I have to say at this point that it's very likely that interferon actually had a role here, because if you are suppressing fever and using aspirin, you are reducing the body's ability to have those types of effects. Once pneumonia was obtained, this is the pre-antibiotic era, 40 and 55% of those patients went on to die. But because so few people developed pneumonia in the sanitariums, the infection fatality ratio was 1/6 of that in the Army hospitals. So are there any other examples? I scoured around and looked and found another example. In this case, it was at the Danish-Norwegian Seminary in Hutchinson, Minnesota. As you can see there, everybody was inside this one building, which is kind of a nightmare if you were to come down with influenza, because there's many seminary students that are in single rooms. And so I went through and found this article, and I'm going to blow this up here on the right-hand side to show you what they said. This is, again, is not a scientific article. This is simply a reporting of what happened. You can see here that in the seminary, there was 120 students that were exposed. 90 of those students came down with illness, and no deaths were reported. So what did they do here in this Hutchinson City Seminary? They say, on the authority of Dr. Fred Shepard, health officer of Hutchinson City, it may be stated that no public institution in the state of Minnesota up to date made a record in handling influenza, the worldwide epidemic that has swept millions into their graves, like that to the credit of the Hutchinson Seventh-day Adventist Seminary. The seminary, with 120 of its 180 students and teachers housed under one roof, was invaded by the malady 3 weeks ago. Symptoms of the malady developed with some 90 of these, and under the direction of Dr. H.E. Larson, a graduate physician, member of the seminary faculty, every person showing an indication of sickness was at once put to bed with a trained nurse taking the temperature and watching for symptoms of the epidemic. If those symptoms developed, the patient was required to remain in bed. So there was already isolation measures that were being taken place to prevent the spread. There was no drugs to be given. So that means no aspirin, because that was the major drug at the time that was being used. But with complete rest and quiet and carefully regulated and fomentations. Now, what's this fomentations? This is the word that's been given for hydrotherapy. So fomentation is where you take hot towels and apply it to the body with the expressed aim to increase the body temperature so the patient starts to sweat. When they start to sweat, that is an indication that the body temperature is being raised. They applied it here to the throat, the chest, and the abdomen, just like we showed you in those pictures from the Battle Creek Sanitarium. This treatment in almost every case reduced the temperature of the patients, and in a day or so, they were apparently well. But that did not end the matter with them. The next danger was that of relapse. To guard against this, every patient was required to remain abed from 2 to 5 days after apparent full recovery, according to their state of flu affliction. Now, I'm not sure exactly what that would do. It could be a hyper-irritation of the myocardium, as we often see with viral infections, that may have stopped them from having issues with their myocardium. They say, as a result of this system of handling a disease that is scoring thousands of victims every day, there has not been one case that could have been called serious or a single death in the seminary, although there were more than 90 people affected. The record is remarkable, and it makes the ordinary methods of dealing with the flu appear irrational. And this article is written by N.P. Nielsen. They end there with basically thanking the efforts of Sister Louise Knudsen, the Seminary nurse, and for the assistance of the other nurses and helpers. And this is really important to understand. This is not easy to do. These hydrotherapy treatments are very labor intensive. I can tell you for a fact, this is exactly what we do in our home with a virus or the chills, is we immediately do hydrotherapy. It is not easy to do. You have to heat up the towels. You have to apply it. There is a foot bath involved to keep the heat in. A lot of interesting things that I'll talk about a little bit later in terms of the protocols that I've read about what they actually did back in the early 1900s. Apparently, we're seeing at least anecdotal evidence. This is not peer-reviewed. These are not scientific articles. We do not have a randomized controlled trial that shows that this works, but there's some interesting evidence, albeit somewhat anecdotal and maybe even case control here at best, that this actually may be beneficial. What we're finding out today is we might be actually seeing why this may have worked. This stuff was done prior to the 1920s. We started developing randomized controlled trials for drugs. Now, I bring that up because giving medications is far simpler, far less labor intensive than doing this type of treatment. And so you can imagine when that sort of thing was discovered, why people went to that instead of this, which was very, very labor intensive. Where did this lead to? This is not the end of the story, because there is actually a transition where we actually go into the discovery of penicillin, and it's basically replacing this type of treatment. So without discussing Julius Wagner-Jauregg, no discussion would be complete, because Julius Wagner-Jauregg, the Austrian psychiatrist, which we've brought up before in previous videos, actually won a Nobel Prize in medicine for a similar discovery. Back in 1917, he noticed in his insane asylum that people with neurosyphilis got better when they had a fever. So he decided to take the most benign form of malaria and take patients with that form of malaria, inject their blood into his neurosyphilis patients, very controlled, and this would induce high fevers in these patients, and this would actually cure them of, up to that point, a completely incurable disease of neurosyphilis. Notice here that they mention that immersion of the individual in a hot bath or placing them in a heat cabinet along with other methods. Any method to get the temperature up would enhance the immune system to be able to actually do that. And we have a picture of him here. This is Dr. Jauregg here in the back, and he is supervising the injection here of one of his patients with neurosyphilis. You can see here that they didn't care much for HIPAA at that time. They're giving blood. I hope they actually matched it and made sure it wasn't different type of blood. He was doing that. He actually won the Nobel Prize in 1927 for his work in 1917. Now, this is important to understand because the very next year after he won the Nobel Prize, this gentleman, Alexander Fleming, discovered penicillin. And as it turns out, penicillin works beautifully to kill the agent that causes syphilis and neurosyphilis, Treponema pallidum. This is a spirochete, and penicillin, of course, was just the first of many antibiotics that were discovered. He did this in 1928 and won the Nobel Prize in 1945. And you can see that the economics of this was such that you no longer needed all of these people to be doing the bath attendance, to be doing the hydrotherapy, to be doing this type of work. This was very labor intensive, and this was probably representing the largest cost in sanitariums and hospitals at that time for making people better. So what we did is we transitioned in that history, in that time of the United States and around the world. We transitioned into finding pharmaceutical medications that would work, that were much less labor intensive and would treat these diseases. I have nothing against the use of these things in the critical care setting, for instance, which is where I work. I use medications all the time. I am grateful that I have antibiotics to treat very sick patients that would otherwise die in my intensive care unit. I am grateful that I have anticoagulants to help with people that come in with terrible blood clots and pulmonary embolisms. I'm thankful for that. But this type of therapy, which obviously was felt to work at that time, even though they didn't have randomized controlled trials, was completely dropped. It completely went out of favor, and we entered into a world of randomized controlled trials and evidence-based medicine looking at pharmacological treatment, which is just fine. However, the problem comes in when we have a pandemic. when we have a demand that is so tremendous that there is no way that we can fulfill the needs with pharmacological medication. Let's remember, it took us a year to get an efficacious vaccine for SARS-CoV-2. Even if we were to have medications that were off-label that could be used for the next virus that comes out, how likely would it be that that medication would be universally available? And this is the reason why I believe that even though we do not have randomized controlled trials, I first of all believe that we should strive to get those so that we can show with proper evidence that this works. But in the absence of that, and because the risks of hydrotherapy are so small, namely burning, which is a possibility, but that can be avoided if you're doing it on patients that are awake, alert, and can tell you if they're hot, or the other side effect would be having a heart rate too fast, it is reasonable to at least think about and consider and understand how hydrotherapy would work. This is a great website that I highly recommend. It's put together by an acquaintance of mine by the name of Bruce Thompson, who studied effectively and in detail the protocols of John Harvey Kellogg and a number who used this type of treatment back at the turn of the last century and also in New England. And so there's a website that we will put in the description below called Hydro for COVID, where they actually go through the procedures about how this is done. Does this have to be done using hydrotherapy? No, you could also do this in hot baths, as we showed. There is question about whether saunas do the same sort of work, or even infrared saunas. Unclear. We don't have a lot of evidence for any of this. I can't say this enough. We do not have randomized controlled trial data that shows that this is effective. But there are some dots that can be connected, and I think what we really need to do is actually get those studies done. I think this is a reasonable website to use, mainly because they're a very responsible website. They say that this protocol is not an alternative to standard medical care. I think that's really important here. This is not to take the place of standard medical care. This should be used in addition. How do I use it? I use it specifically for when I start coming down with something. I may not go to the doctor for something so small and insignificant, but if I can head this off before it becomes something bigger, then we should do that, I think. It's a really good website, and I would highly recommend it. They also go into what the fomentation and hot foot baths look like in terms of heating up the body temperature. Here's the actual book that John Harvey Kellogg wrote on a lot of this information. This is not something that's just in the past. There actually are scientists looking at this currently, and you can see this here. This was published back during COVID 2021. Published online in late November, even before the vaccines came out, titled Hydrothermal Therapy in Prevention and Treatment of Mild to Moderate Cases of COVID-19. We have talked on MedCram about sunlight. We've talked about nutrition, exercise, fresh air, getting plenty of sleep, the temporizing effects of diet and healthy living. And now we add to it the free and liberal use of water in terms of supporting your immune system and counteracting some of the effects that SARS-CoV-2 does to your innate immune system. If you enjoyed this video, please join us at medcram.com, where we have continuing medical education videos. Thanks for joining us.